Well, hello everyone, and welcome back to the National Academy of Certified Care Managers exam prep course series. Just as a reminder, all participants are in a listen-only, view-only mode. However, throughout the presentation, you have the ability to send your questions through the question pane or chat pane. Simply type in your question and click send. Today's topic is entitlements, benefits, and legal issues, and our presenter is Connie McKenzie. Connie is the founder of RN Life Care Advocates based in Jupiter, Florida, and has worked in the field of aging and disability for well over 25 years now. She's a registered nurse and certified care manager of NACCM. She's an advanced professional member and or not immediate, but a past president, excuse me, of the Aging Life Care Association. So with that, please welcome Connie.
Hi, welcome everybody. Congratulations on your endeavor to get certified. So we are looking forward to all of the education you're going to continue to learn because this is a great opportunity our association offers. So let's get started today. We're going to look at the learning objectives today. We're going to be reviewing the following areas: Medicare, Medicaid, Social Security, disability insurance, supplemental security income, veterans benefits, and also advanced legal benefits. We hope that you will be able to, at the end of this presentation, explain the differences between Medicare and Medicaid, describe eligibility criteria for Social Security disability and supplemental Social Security income, as well as understand the eligibility criteria for veterans aid and attendance benefit, and describe the application process. Last, we will discuss advanced planning tools and explain why these tools are very important to your clients and for you. Next slide. Okay, so we're going to start with Medicare and Medicaid. I feel it's so important for an aging life care professional to learn the language and above and beyond, but to know the language of Medicare and Medicaid benefits to guide your clients, their families, as they navigate long-term care options that best suit their needs. So we're going to first talk about Medicare. As you can see, that card you're probably very familiar with. It is a federally funded program. It's an entitlement, okay, for those over 65 or certain people, younger people with disabilities, as well as people with end-stage renal disease. You can also, if you pay into the system, you are entitled to the benefit. We all know that by our paychecks that we pay into this. You can also purchase Medicare if you are not entitled. And I just had one of my first, I've had a couple that have paid into Medicare, so it does come up. You must be 65, of course, if younger, if you're disabled, and the disability process is you have to be disabled for 2 years prior to receiving Medicare. It is not a means-tested benefit, and it does not pay for long-term care beyond rehab days. Very important, frequently asked question by families. Medicare numbers were changed several years ago. They used to be based on our Social Security number, and now they are random numbers. There's actually an equation for those. If you're interested, you can go to medicare.gov. Sometimes the copies that we get from our clients are kind of ruffled and all the numbers off. So sometimes you can figure it out just by knowing that equation. Let's see. Okay, next slide. When we're talking about Medicare, it's important to understand the different parts and the benefits associated with each, because our clients and families are maybe dealing with it for the first time to understand what their benefits are as they are dealing with an episode or an illness. So Part A it covers inpatient hospitalizations. It can also cover an inpatient in skilled nursing. Generally after a 3-night overnight admission, and you see here that it is underlined because sometimes somebody can go to the hospital, remain in the emergency room, and not really be admitted for that first night. So that's really important to understand. It will cover hospice, and it also covers some home care under an order from a physician. There may be a deductible to meet, which may be covered by most Medigap plans. So we're going to talk about Medigap or secondary plans a little later on in this presentation. Part B, this part covers doctors' services, hospitals as outpatient, and also some home health care. It does also cover some preventive maintenance type of wellness checks. It may pay for additional therapy, even if you're in a nursing home, that Part A may have ended and you're then getting a maintenance program within a rehab setting. Generally, it pays 80% of the Medicare approved amount for covered services after Part B deductibles have been met. This with an exception of most preventive services, Medicare pays 100%. Part C is the Medicare Advantage plan. Very much like any other healthcare, like if you go to the Obamacare, they have HMOs and PPOs, and they're all run by Medicare-approved private insurance companies. Medicare Advantage plans are inclusive of Part A and B and usually have coverage for prescription drug coverage, which we're going to cover below. So often a choice for individuals to select a Medicare Part C versus traditional Medicare with a secondary, as it is can be a cost savings to some individuals, or they want the expanded benefits that are offered under a Medicare Advantage plan. Medicare Part D is the prescription pharmacy plan, also run by Medicare-approved private insurance companies. It helps cover the cost of prescription drugs, and it may also help lower prescription costs through these companies that they may not have had access to. Important to know that each of those providers have their own formulary. So checking through Medicare.gov helps you figure out a Medicare Part D plan. And we're going to talk a little more about that when we specifically talk about Medicare Part D. Next slide. Oops. So basically, it's important when you're looking at the basics of Medicare to understand that it is a state health insurance assistance program and provides in-depth, like insurance counseling. Is available through Medicare, for Medicare beneficiaries. And you can get this through a provider called SHIP, and it's offered in almost all the states to help understand how to make these choices, and as well as understand your policy. Medicare is the program that you must enroll in. And so when you initially start, the A is automatic. There's no cost associated with it. Part B, again, is the physician, and there's premiums and deductibles associated with that are independent of each individual's and each beneficiary. And their basic premiums are set every year. It's set according to the COLA and taxable income from 2 years prior. So when you sign up for Medicare, you get Medicare Part A, and your Medicare Part B is based on your income. And as that changed over the past 2 years, you would have it's all evaluated. The standard Part B premium this year is $185 per month. People with a higher income will pay more. Additional amount is called income-related monthly adjustment amount. It's called an IRMA. And with that again reflects back to your 2 years of taxable income that was reported. You do not sign up every year. It's just this would be the initial sign up for Medicare. Initial enrollment is at age 65, as I said. If you don't enroll, this is important because some people have missed this. When you become eligible, and you do not have any credible insurance. If you're employed, you do not need to sign up for Medicare, but that's considered a credible insurance. You then, if you didn't have incredible insurance, you could incur a penalty. And that is goes across the board for Part B and D. And it's a multiplier of 1% of the national base beneficiary premium, which for Part D is 3678 in 2025. So signing up for Medicare when you're eligible, understanding the benefits to which you are selecting and the costs associated with them is really important. Next slide. Now we're going to kind of tweak these and open them up a little bit to just really understand each of our benefits. If Part A is hospitalization, Part B is outpatient. This includes mental health services. It covers diagnosis, medication visits to your physicians, um, counseling, um, annual screening and annual exam. Also, some rehab after full coverage ends. You can get that at home under a Part B if you've been inpatient in a rehab, discharged home. Part B can continue to cover as an at home or as an outpatient. In all areas of Part B, these services, there is a deductible associated with that. And generally, in that deductible, if you have a Medigap policy, it helps cover that. Um, Items not covered by original Medicare are routine dental care, dentures, any cosmetic surgery, hearing aids, hearing exams. These are not covered by most Medicare. And so that's another reason people may select to expand their benefits and select a Medicare Part C, which again, we will talk about. There are two types of services under B, and it's what's medically necessary, and then preventive services like our health exams. Okay. The maximum 2025 premium, I didn't add that last, but the maximum one would have to pay if you have a high income would be $625.90, just to give you a relative term. So the standard would be 185 and the highest would be 628 based on 2025 numbers. I want to give you that range so you know what to expect. Next slide, please. Okay, so Medicare Part C is often called a Medicare Advantage plan. These plans often provide expanded coverage above and beyond what original Medicare covers. There are several types of models of Medicare Part C. You'll see an HMO, a PPO. I have a client that has their Part C covers part of the B um, payment, their copays. So it usually is a rate. Referrals are needed under all of this. If a physician wants to make a referral to a specialist, it usually requires a referral to a specialist. Must cover everything in traditional Medicare, but also may pay for additional services, like we said before, dental, hearing, eyeglasses, home modifications. Some I've even seen pay for a little bit of home care. And after a discharge from a hospital, we see Meals on Wheels being paid under a Medicare C, Medicare Advantage plan. So you can see for some people, it has some advantages. It may also allow hospital diversion, meaning to bypass that 3-night rule that Medicare requires. That's very specific to each of those plans. So if Medicare has a requirement of a 3-night night admission in a hospital before you can be admitted into a skilled nursing facility for rehab, it's not across the board. You'd have to check about the Medicare Advantage plan to see if they have a different rule that they are covering. Generally, Medicare under a Medicare Advantage plan when you're in a rehab is probably less days. It's very carefully monitored, and maybe the goal is to get them discharged as soon as possible, where Medicare traditional may be a little more lenient. Then the 2019 rule will allow test drives on Medicare C. So if you select a Medicare Part C, a Medicare Advantage plan, these plans will allow you up to 3 months to see if it's a right fit, a right benefit for that individual. And end-stage renal disease patients can join as of 2021, but need to be very careful in reviewing these benefits because they have to know that their providers are all inclusive with this provider. So these plans are becoming more popular. People make these decisions for different reasons. And I think it's important to know that if you want to change a Medicare Advantage plan, there's an open enrollment period from January 1 to January 31st. Um, and again, Part C also is an alternative to Medicare Part A and B, and it's inclusive of that. And they do not require a Medigap or secondary insurance. So understanding if someone comes with a retirement plan and that acts as a Medigap policy, be very careful because it can impact that plan and they would not be able to get that back again. Next slide. All right. So now we're talking again about the prescription drug plan, which is Medicare Part D. Okay, yes, it's voluntary to cover these drugs offered to everyone with Medicare, but you must enroll. The same rule applies. Medicare Part D coverage, if you don't sign up originally when you're eligible, you will have a penalty for every year that you did not enroll or have a policy in place from another provider. They're the same enrollment period as Medicare. You'll be offered that initially when you sign up for Medicare. You can also purchase standalone plans as part of your Medicare C, Medicare Advantage plans. So although with traditional Medicare, you can get A, B, and D under a Medicare Advantage plan, they are sometimes inclusive, or you can add a plan that stands alone. I hope this is a lot of different words, but it's very important to understand this language. If you don't take when you're initially eligible for Medicare, that's just when you sign up, and you're not covered by a credible plan, you will again pay a penalty. So we do get families or children that ask us these questions as they approach the age that their parents were eligible for Medicare. We can all come to a conference and talk about different plans, but they are different by region. The costs are different and specific drugs covered. So if your client is on a list of medications, you need to run it through each plan to see what their formulary covers. And as of January 1, 1921, there are a new special plan to cover insulin. So the cost of insulin, the Part D plans typically have a deductible copay, and the inflation plan as of 22 lowered that out-of-pocket limit for 2025 to a limit of 2,000. The insulin cost is what we're referring to here is capped at $35 per month for a D beneficiary, Part D beneficiary. So between deductibles and formularies, there is a lot that you can explore on the Medicare.gov by exploring these plans. And I suggest you kind of put your own meds in there and just kind of test drive some of these online opportunities to navigate what plan's best. There are, as I said, the out-of-pocket for 2025 is 2,000, and that changes every year. Next slide. Medigap is also, it's a supplemental plan, secondary plan you often hear, but it's secondary only, to the original Medicare benefits. It's sold by private companies, private providers. You can go by state and look at who's available under your state to access the Medigap plans. What Medigap does is pay for what Medicare doesn't cover. So if they cover 80% of a physician's visit, the Medigap policy would then pick up the 20%. It's like like a copay or a co-insurance, but it does also have its deductibles, and that is based on the plan that each person selects. Some plans may have longer coverage than one-time deductible, so very specific. Again, Gov or any of these, you can compare these plans to weigh one benefit against the other to meet the specific needs of your client. Generally, the Medigap policy does not cover long-term care in a nursing home. It doesn't cover vision, dental care, hearing aids, or eyeglasses, and it never covers private duty nursing. But again, specific plans can change, so it's always good to reevaluate that. Since 2020, may not be able to buy a plan that covers the Medicare deductibles. So that was instituted to members that would bear some cost of care. It's still, I've seen, like I just mentioned earlier, a plan that did cover the Medicare Part B under that. So under the Medicare C. So sorry, I correct that. That's not under Medigap. So again, you just really need to look at each of these plans and weigh out the benefits to each specific client needs. Next slide, please. So Medicare and home care equipment, very specific. Home care services are covered under A and Part B of traditional Medicare. Typical services would be like when a physician orders PT, OT, and speech therapy or skilled nursing visits. As of 2019, there are no more caps on therapy services. They must be homebound to receive this benefit. Homebound meaning that they maybe a post-hospitalization or no longer can get out to a physician. That the schedules are pretty open for these providers to come in specifically at the times that their schedules permit. The client pays zero. There's no cost for these services. They're fully covered, but some may have a copay for PT if they don't have a Medigap policy. All the services must be certified by the therapist for the number of days that are going to be provided to the beneficiary, how many times per week. They can authorize it for 4 or 5 weeks, 6 weeks. And then as they progress and meet the goals, then the therapist continues to decrease the services until discharge. Each of those visits require, prior to starting, a face-to-face visit with a physician within 30 days of ordering those services through their Medicare. Medicare, the good news is, now covers more telemedicine, and that has been so beneficial to long-term care community and working in the home. Also, the Medicare covers durable medical equipment. The client, again, may pay 20% of the Medicare approved amount, but if they have Medigap policy, it would cover that based on the policy. And there is a deductible that applies. You must use the companies that are Medicare certified and that follow the physician's orders. You have to weigh out every one of the orders. And examples of this is listed as oxygen, wheelchairs, hospital beds, but they're all associated with a diagnosis to support the medical need for this type of equipment. Next slide, please. This is always a question. Someone goes to the emergency room and the question is, have they been admitted or are they still in an observation status? Observation patients are billed as an outpatient service under Medicare Part B. Inpatient admissions are billed under inpatient service under Medicare Part A. So observation patients may have insurance copays associated with their hospital observation period and deductibles. So that's important to understand. Um, there are some plans that make under Medicare, those residing in some facilities who require nursing home care are people with certain chronic or disability conditions. So you must confirm a status to ensure that rehab coverage is if a client has been on original Medicare and certain other plans. If they require an admission, it would be to be transitioned to a rehab. It requires a 3-night hospitalization admission, and that is important to know that maybe they were in observation status for 24 hours and then admitted. So you've got to be aware of their status and ask the hospital what date they were admitted. If you have not been admitted and you want to dispute that because you feel it was nothing that the beneficiary did, you can try to appeal it as well. The families will ask about this quite often. And all case managers in an emergency room, as well as in a hospital setting, are very much aware of the advantages and disadvantages of admissions and of observation status. Next slide. So we experienced a great deal of changes when we were during the pandemic, and a lot of Medicare guidelines changed. So CMS looked at emergencies very differently during that period, and at that time, they waived the 3-day requirement, and spell of illness and the illness is required for anybody who had to be evacuated or had COVID. So there's different requirements that can be requested. If, say, we here in Florida, we have hurricanes, like the fires in California, and people are admitted. So there's different things that can require CMS to review that request. Medicare has relaxed those guidelines in cases such as this, as natural disasters, and certainly we've seen a lot of that over the last few years. So it allows some flexibility as well for prescription drug coverage. Some that had to be out of network, some had to be refilled because they could not access their medications. They may have been destroyed, and so they're going to have an override on that. They can use out-of-network providers sometimes in Medicare Advantage's plans because of the access. So you really need to understand your relationship and checking with the CMS regional office if you have very specific criteria that you're concerned about for your client. And again, I think when you expand under Medicare Advantage, you might have access to more benefits, but a Medigap policy, only what's the supplement outlined in the supplement is going to be covered after Medicare. And so understanding all these points and advocating for the greatest benefits for your clients in special situations is certainly an advantage. Next slide, please. Okay. So there's Medicare savings programs, and they can help with, we've kind of alluded to it in some of these underlying benefits. They can sometimes pay for Medigap premiums that are not covered. They can help with Medicaid programs, state programs, Medicaid programs. They look at federal poverty levels that change every year, and states may have more, but not less general standards. So you really have to understand your own state programs. There's a program called Qualified Medicare Beneficiary Program, referred to as QMB. And as you see, it covers if you meet the financial criteria limitations, then it can help pay for a Part A monthly premium when applicable. Not always is that. Definitely Part B monthly premiums and some deductibles, and also co-insurance costs and deductibles. Monthly income must be at or below the annual federal poverty level for the beneficiary to qualify for the Qualified Medicare Beneficiary Program. The other program that often we see is specified Low Income Medicare Beneficiary Program, the SLMB, and then payments of the Medicare Part B premium can be, well, it's not really waived, it's paid by this program. And your monthly income, again, must be between 100 and 120% of the annual federal poverty level. All programs that can help your client utilize those funds differently in what their life care needs are. We also have a qualified individual program, and you must apply every year for this qualified program. It's granted for on a first come, first served basis based on each state's funding, I guess, yeah. Payment of the Medicare Part B monthly might be, again, part of this program, and individuals, again, must be within the income between 120 to 135 of the federal. So as you can see, each of these programs go up with the needing a less income. Qualified Disabled Working Individual Program, very interesting program. Payment for Medicare Part A monthly premium it covers, but options for working disabled persons is under 65 and who have lost their premium-free Medicare A because they're no longer working. And when returned to work, must not be getting medical assistance from the state. So you must meet the state's income and resource limits. And again, you going to research all of these programs, you'll need to know your client's work status, disability status, and income. But again, it is all based on each state's requirements. Okay. Okay. Next slide. I keep saying about alluding to Medicare.gov. That's a great resource, but we also have these other agencies that can help you, your clients, and your families navigate a lot of Medicare questions and be advocates for maybe some unusual circumstances or specific details that may not fall within the information you're accessing. There's the Medicare advocacy teams exist throughout the country. There's great websites to sign up for so that you can get constant emails and updates for unique situations that have maybe had been litigated or new guidelines, new laws, keeping you up to date. The official website again is medicare.gov. I think the other, there's a Medicare handbook, the Medicare and You handbook. You'll see your clients receive this usually annually. It is a great handbook to have in your toolbox. It outlines everything that Medicare offers and all the plans specifically for your state. We all can also appreciate AARP has a great resource center, helps, you can refer your clients. There's a lot of educational information to help them make decisions about their Medicare, Medigap, Medicare Advantage that can be more objective than just going to a very specific insurance company. The Justice and Aging Project, you can go to their website and sign up for their emails and education. And attending some of these, there's offerings in each of these that may help you learn about Medicare. Okay, next slide, please. Okay, well, then your families always say, my mom has Medicare, or is it Medicaid? And so you'll define this many times as you in your professional career. But Medicaid provides health coverage to millions of Americans that are low-income adults, children, or disabled individuals with individuals' disability. It is a joint federal and state program. That's why when we say you've got to go back to each state to look at the benefits, because it can differ. It, together with the Children's Health Insurance Program, provides coverage to over 72 million people. And it's a program that we often are dealing with our clients, because the most popular program, and we'll go into some of them, is the institutional care program benefit. But it's means tested, so you can't qualify unless you are at the be on or below the threshold. And there's lots of rules associated with each of the benefits, and it's there to cover medical care. It, as I said earlier, it covers institutional care like a nursing home in some states, and it also will cover some community-based or long-term care services. There's a lot to learn here, so let's move on to the next slide. The waiver programs. So these are vehicles that states use to test new or existing ways to deliver and pay for health care in Medicaid with children and adults. And there are four primary types that we're going to talk about here of the waiver programs, or they call them demonstration programs. There is the, the section one, but it's research and demonstration project. The states must apply for the program. It is flexibility to test new and existing approaches to financial and delivering Medicaid and insurance to children. So that it's not a program, it differs every year. It's what they apply for and what they get the funding for within each state. Managed care waivers. States can apply for the waivers to provide services through managed care delivery systems, or otherwise limit people's choices or providers. These are all programs, again, specific. Um, the other one is home and community-based services, of which we do see a lot of use with our clients. States can apply for these waivers and provide long-term care services in the home and in community settings, and the goal is to prevent institutional settings so that people can remain in their home. The last one is a waiver, a concurrent section waiver. And these can, again, the states must apply for these. And there's two types of waivers to provide continuation of services to the elderly and people with disabilities, as long as their federal requirements for both programs are met. So a little complex in the language, but maybe we can drill down on some of these that we use, and it will make more sense. The biggest benefit to home and community-based services is the beneficiary can remain in their home or community instead of being sent to a care institution. Next slide, please. So one of the options available in most states allows the provision of long-term care services in the home and community-based, but not all individuals can afford to stay in their home. So offering them additional benefits through the Medicaid program allows them to possibly meet this goal. They're specific to each state. And they can provide a combination of standard medical care, and some are not medical services. They may have some additional hours for a home health aide so that they can be at home getting assistance with their activities of daily living. Some of the standard services include, but are not limited to, case management. They may have multiple comorbidities and qualify for specific programs under these community programs. They may just need, in order to stay home, a homemaker, just personal care. They could also look at adult daycare, both residential programs, and often respite care is covered under these waivers. States can also propose, each state, however they're different services that may assist in diverting and transitioning individuals from institutional settings into their homes and community. So the clue here is the money follows the person. Once they've been authorized for these services and they're under a benefit claim on a waiver program, the goal is to have the least cost of care so they can move back and forth to these programs. Programs have proven challenges in some states due to the high cost of many of those care plans. But particularly the challenge in, anybody that's over 65, it's just how do you get access to these programs? And that's where care managers come in. We educate them to the waiver programs and what they may be eligible for. I think that when you learn these programs and you can share options with your clients, you can blend all the medical care and these waiver programs with home care opportunities and resources, daycare opportunities to bring it together under a one umbrella of care plan for your client. Okay, I'm sure there's lots of questions here because there's a lot of information. Let's go to Social Security. Next slide. So Social Security is an entitlement program. If you pay it in, you're entitled to receive benefits based on your work history and reported salary. We all pay into it through our employment. Benefits amounts are based also on the date of your retirement. We often have that question as well from mostly our children of our clients, to what's a good time to start receiving Social Security benefits. This is based on the year of your birth to when your retirement age is. And so not therefore, it's not everybody at age 65 like it used to be. The earliest age for retirement, not on disability, is age 62, but retirees will forfeit benefits. So the earlier you take your Social Security benefits, the lower the amount you receive. The maximum benefit at age 70. And there is also a penalty if one works while collecting Social Security before full retirement age. Divorced individuals, we do see that a lot of questions, who have not remarried may collect on their spouse's benefit record, regardless of the ex-spouse's marital status. So they divorced, their spouse remarried, but they did not. So their file goes back to their ex-husband or ex-wife, whichever way it goes. And without harming the spouse's future benefit if married at least 10 years to the other spouse. I'm trying to think of anything else. Okay, next slide. So Social Security Disability, SSDI, it's a federal program. It gives cash benefit to people with long-term care disability. Long-term care disability is important to understand, who qualify because they used to work or have family members who worked and are now disabled. It's not a means tested, important to differentiate. No income or resource limits. It offers benefits to family members, including children and widows, when a primary wage earner in the family becomes disabled or dies. Adults whose disability began before they turned 22, important again, may be able to get childhood disability benefits based on their parents' record. So difference here from supplemental SSI, supplemental Social Security insurance, which means that's means tested based on your incomes. So it's important that you understand the differences between SSI and SSDI. SSDI benefits are eligible for Medicare after they've been disabled for 2 years of receiving benefits if they're under the age of Medicare. So that's also something that you would need to follow. Okay. Next slide. In order to qualify for a disability program, you must be able to for SSDI, be unable to work because of a medical condition that is expected to last at least 1 year or result in your end of life. The other is not have a partial or short-term disability. If one does have a partial or short-term disability, they will not qualify. And they must meet Social Security Administration's definition of a disability, which you can access on the Social Security website. And you must be younger than full retirement age. So certain family members of disabled workers may be eligible to receive benefits based on the work of the disabled worker. Children under 18 or full-time students would be eligible. Next slide. Second. So we're going to go briefly over this because this is a pretty deep conversation and you can access too. But the definition of a disability, you cannot do work that you did before. And Social Security decides that you cannot adjust to other work. You can't take vocational training and have access to another work, substitute work, based on your medical condition, and that your disability has lasted or expected to last for at least 1 year again. The monthly financial assistance determined on your average lifetime expectancy begins the first day of the 6th month of the disability. When you turn full retirement age, it then converts to your retirement benefits. So disability under 65, and then when you turn, or whatever your year of retirement age is, it would then convert to your retirement benefits. Medicare benefits provided after the person receives disability is after 2 years. Compassion allowance for cash benefits for certain conditions and diseases like early onset dementia, ALS, can also be considered under a disability. The process, I have a couple people in the process right now, is a long process and one that often can require the help of a disability attorney. Next slide. Supplemental Social Security, SSI. This is when you have to be 65 and above, blind or disabled. You have state-specific rules for the application process, including a disability review. Benefit may depend on your living arrangements. The definition of disability is a medically determined physical or mental impairment, and it results in the inability to do any substantially gainful activity and can be expected to result in death as well. So very similar to SSDI, and has lasted or expected to last 12 consecutive months. And you are looking for monthly financial assistance, and Medicaid benefits may also be provided under SSI. The major difference between SSI determination is based on age and disability and limited income resources, where SSDI determination is based on disability and work credits. So important, that one statement I'm going to repeat, the major differences is that SSI determination is based on age and disability, age or disability, and limited income and resources, where SSDI is based on your disability and work credits. Next slide. Okay, we're going to cover, outline some benefits here under the veterans services. Under the veterans pension programs provide monthly payments to wartime benefit veterans who meet certain age and disability requirements and who have income and net worth within limitations. So in order to is a benefit paid to, you're eligible under this pension if you are a wartime veteran. You must have served during a wartime. You have to be 65 or older with limited or no income, totally and permanently disabled, or a patient in a nursing home receiving skilled care, and receiving Social Security disability or receiving supplemental Social Security, SSDI or SSI. This program offers monthly payments to qualified surviving spouses as well, or unmarried dependent children. We're going to go into that. Next is a program called, next slide, Aid in Attendance. This is considered to be a third tier of VA improved pensions. There's a basic, household, and then this benefit. So as of the Aid in Attendance is, again, a pension program, a benefit, and it's paid to wartime veterans who were honorably discharged, veterans requiring aid of another person with their activities of daily living. Payment typically assists with the activities, assisted living, the payments can typically help with assisted living costs or in-home care. It may also be payable to a surviving spouse if married to the veteran at his or her death and has not remarried and meets definition of need. So they meet the same need of needing assistance with activities of daily living. Also, they have an income or asset guidelines. Major changes to the program as of 2018. Before, they didn't have strict guidelines. Asset guidelines. Now it's tiered to the Medicaid guidelines. You can't have more than 123,600, and your income may be where it's not really based on. It's your income is offset by your medical expenses. As I want to show, as of 2025, this year, the Aid in Attendance program rate for a single veteran can be up to $2,358 per month. And while a married veteran with a dependent is eligible as well for $2,795. So it changes every year, these benefits. Next slide. So the VA can be complex and time-consuming to figure out. There's plenty of people to reach out to in each of our communities that can help us navigate this. There is legal planning that can or should occur, especially to ensure that plans do not interfere with future Medicaid benefits. There is a 36-month look-back period for transferring assets under the VA. Payments, once you apply, it takes some time to obtain these benefits, but they are retroactive back to the date of your application. A surviving spouse is only eligible if she's married to the veteran at the time of the veteran's passing. If the spouse of the veteran needs assistance, but the veteran does not, may not be eligible for aid and attendance add-ons. Information is available at the va.gov website, a great place to access, as well as local community, and you must be VA certified. So none of us would offer this benefit unless you're VA certified to prepare a claim, even aid and attendance. There are national, local, and private resources to assist, and they're fantastic. There may be a state veterans program, which may have some differentiations from our federal ones. So you need to check through your local providers under the VA. Okay, next slide, we're going to talk about legal issues. So what is a will? And I'm sure all of you understand that what a will is, but the legal test for this is a document that is executed by individuals directing those that will be directing what your estate is to be distributed, how your estate is to be distributed. It does not give authority to the executor who's they've appointed to do anything during the individual's lifetime. They're not responsible to the person as the titles differ. Excuse me, let me read that. Does not give authority to the executor or other responsible persons to do anything during the individual's lifetime. The will is upon death. The person to execute must be of sound mind and have testamentary capacity. we define this over here because it's really important, and I've seen this so many times through my years. Testamentary capacity does not require that the person be capable of managing all of her or his affairs or making day-to-day business transactions, nor must the testator have capacity consistent over time. Capacity is required on the day the will is executed. So it's interesting, and I've seen many people that have not managed their lives, but they're able to execute a will. You must be of legal age to execute a will, which is 18, and wills can be simple. And boy, have we seen some complex ones through many of the clients that we've had, because there's just battles often we see. So beware, that's something we always have access to, but sometimes there's some litigation because somebody may have changed a will, so you may have access that way. Next slide, please. What is the power of attorney? Power of attorney gives one or more persons the power to act on the individual's behalf. It's important to understand this language because we always ask for who has the power of attorney. A durable power of attorney does not terminate upon incapacity of the person making the power of attorney. The power may take effect immediately or only upon an occurrence of a future event, such as incapacity. If it activates in the future, it is called a springing power of attorney, and that language would be used in that document. It may be revoked, but most states require written notice of revocation to that person named. The person authorizing the other act is the principal, the grantor, or the donor. The person named in the power of attorney to act on a person's behalf is commonly referred to as the agent or attorney in fact. The agent can take any action permitted in the document. I apologize. So sorry. I didn't know my phone was off, but it came on my computer. Okay, I apologize. So the agent can take any action permitted in the document. They can establish whatever the person has outlined in that document. Okay, next slide. More specifically to the durable power of attorney. Oops. We do request a copy of it and we try to read it and understand so that we understand who we're taking, who's making the decisions. Individually should not give away originals unless it's necessary. So we take a copy, we never take an original. The ability to contract and give consent, also ability to make gifts. So that power of attorney outlines that. Remember, there may be limited in time or scope of durable power of attorney. So it does survive incapacity, but again, that is outlined in that document. But once it's signed, it is usually effective. Next slide, please. Durable powers of attorney are not recognized by federal agencies. Very interesting, such as the VA and the Social Security Administration. Each of those agencies will have their own process for determining representation or fiduciary responsibility. So DPOAs can be very broad or have specific restrictions, and many places refuse to recognize old documents more than 5 years old or may need to be recertified by the attorney who originally executed. Many people also download forms from the internet, then not tailored to the specific situation. So knowing where those documents came from and who executed them is very important. Next slide, please. The HIPAA releases, we all know what that is. We sign them all the time. We strictly adhere to our HIPAA guidelines by protocol. All patients' protected health information, how we access that is very important. Our respecting their confidentiality. Uh, Good idea to, really have medical records prior to the need is just to is ask for a HIPAA release and then protecting their information to which you're obtaining and only releasing to those that need it. Next slide. The healthcare directive. So healthcare proxy, often called uh, living will. Any document that gives instructions about your health care and your appoint someone to make medical decisions on your behalf. This living will or the durable power of attorney, often called for healthcare, is the document that you need to review and understand the individual's wishes. There's also documents that are called the POLST, which is a portable medical order in some states, and the MOLST, M-O-L-S-T, medical order for life-sustaining treatment. Both of these documents are now being used. So familiarizing yourself with what's in your state is used and is important, and to review them. If your client hasn't executed a living will, it's an opportunity to really have a discussion with them that what matters most to them. Next slide. The healthcare proxy, again, it provides informed consent, makes decisions. The surrogate believes the principal would want if they're unable. So you're standing in their shoes when you make that decision. It's based on their expressed wishes. It would withhold, or you can withhold or authorized treatments. Usually you can even sign a DNR. It's all based on that living will and the individual's wishes. Next slide. What if they haven't executed a healthcare surrogate or selected? Then it usually goes, you have to know what your state laws are. It goes then to a spouse, or if there's no spouse, children, and then family members. So it's good to know that before so that you're not trying to find how to navigate that in an emergency. Next slide. This is exactly what we've said. The living will is if you're terminally ill, it expresses what you would want for yourself. It's not recognized as a legal document in every state, but the document in which a person states their wishes about life-sustaining medical treatment if terminally ill. Next slide. This is just another example of some states. You can see which ones are using these forms. So you do need to know specifically which ones are in your state. Even if your state does not recognize the 5 wishes, it outlines, what the person's wishes, but it's a great way to have a discussion with a client. Other than just a simple living will, the MOLS, the PULSE, and this 5 wishes is a great tool to review so that if you're the one having the discussion with your client, it allows you to have a very sensitive and comprehensive discussion. Next slide. I apologize, we're running a little behind. Guardianship. Oops. This conservatorship, guardianship, these are legal arrangements that give a person the authority to care for another person. The guardian makes the decisions about the ward's finances, health, and daily life. It's all very specific to what type of guardianship it is. And all these guardianship is usually related to the person. Conservative is usually related to the assets. And again, that is very state by state. But both guardianship and conservatorship are a court legal process, can be expensive, and the documents are generally public. A medical certification from a physician is required to move forward with a petition, and it is then evaluated by a guardianship team to determine capacity. You can also go to the National Association of the National Guardianship Association for additional information. It will outline, what a limited guardianship is and the difference between a plenary guardianship, which is totally making decisions for an individual, their medical care, their life care, could be finances, as all outlined in that guardianship document. Next slide. What's the advantage of guardianship? I mean, there's one that now you have court supervision um, and over their person as well as their financial affairs. It protects the person unable to help themselves. It refuses help who maybe refuse help. This is a way of getting them the help that they need because of their incapacity. It's a deterrent to individuals who might wish to take advantage of the ward, and it is a deterrent to those who might wish to inappropriately use the ward's assets. So it does have some advantages. Next slide. But I think although there are some advantages, there's some disadvantages, and it's always determined. Guardianship should be the last resort. Is there any other less restrictive ways to achieve the goals and protect the individual? We want to protect because it's intrusive, it's burdensome, there's reporting, there's limitations to, there's processes that now you have to go through. So trying to prevent it, but often it's something we can't prevent. It is expensive, and it's not, it can be charged to the client, the beneficiary's estate. So it is a last resort, and there's lots of creative ways to try before you get to guardianship. So, well, I'm happy to address any questions and answers. I apologize for a few minutes running over, but if there's any questions, I'm happy to do.
Thanks so much, Connie. And I think we have had a variety of questions come into the chat, which I will start off reading if we have time to answer a few of them. Early on, question came in about were the insulin lowering measures recently rescinded by the current administration? I'm not sure if you have an answer to
I
that.
not heard that it was. The last I saw on the website, it was not.
Thank you. And
But
oh, go ahead.
no, but
Okay.
obviously things change day by day right now.
Exactly. So, are the income requirements for Medicare savings programs gross or net income?
I believe they are gross. Hmm.
And are there any limitations such as married for 25, divorce over 30 years? And when the spouse gets Social Security, what is the amount?
So if that person's looking for Social Security from an ex-spouse, then as long as they didn't get married, they're entitled to whatever, it's based on the spouse's amount that like how much he paid into it and how much he gets out of it. So there's not a specific amount under Social Security. If that divorced person is uh, applying for benefits under Social Security under their ex-spouse benefit, it's based on their amount that they earned and what they are being paid for Social Security. So there's not a number, a specific number. If I'm catching the question correctly, I apologize if I'm not.
Thank you. And I'll just ask Sarah to pipe in for any clarification that she might need. And I think an additional one that just came in a few minutes ago was how can a patient who was receiving home care through Medicaid continue receiving home care services under their secondary Medicare insurance if they lose Medicaid coverage?
So there's secondary medical insurance being a Medigap policy. If that's it, it starts with going back to their Medicare and having a physician's order under, and it'd be mostly skilled. It wouldn't be non-skilled once they've exhausted the benefit under Medicaid. It's so easy. It's so hard to have answer a question without discussion, but read that again, please. Read the question again. I want to make sure.
Absolutely. How can a patient who was receiving home care through Medicaid continue to receive home care services under their secondary Medicare insurance if they lose Medicaid coverage?
Okay, so that is the answer. So
Okay.
just because you're on Medicaid at home under a waiver program, possibly, you still have your health insurance coverage, whether it's Medicare with a secondary or a Medicare Advantage plan. It doesn't impact those benefits.
Excellent. Thank you so much, Connie. We got through everything and even to a few questions in the end. So I really appreciate you sharing your time and expertise on this important topic for us today. On behalf of NACCM, we thank you. We thank all of our participants for joining us. We'll be in touch again with a recording of this event to review, maybe even one more time before you take that exam. And appreciate any feedback you have for us. Our final session will take place tomorrow, same time, a slightly different channel. I'll be in touch with a more information on how to log on. So with that, we'll go ahead and conclude today's event. Thanks so much, everybody.
Good luck.